Okay. So I welcome all the participants for this 15th Zoom meeting. And today we have Dr. Shiju Majeed from Trivandrum Medical College. He is an associate professor in spine unit of orthopedic department. And he'll be sharing his experience in managing rigid scoliosis, how to manage and various osteotomies involved in it. And at the end, we will have a sort of a panel discussion with Dr. Shiju. Dr. Vishnu will be moderating, and Dr. Prince will be joining us. And queries will be based on if time permits, Dr. Vishnu will show his cases, and we can have some sort of discussion how to manage ahead. And this will be the sort of presentations in future also, so that it becomes more interactive. So I request all participants to actively involve in the chat also. So Dr. Shiju, you can go ahead.
Yeah, Ram, good evening. Thank you for giving me this opportunity, and I welcome all the delegates, the Zoom viewers who have joined us. Ram, am I clear in the audio part?
Yes.
Yes. Okay. Thank you. So greetings from Trivandrum, the southernmost part of Kerala, and this presentation is actually from myself and one of my colleague, Dr. Ashok, who together we do this kind of rigid scoliosis. So we know when you get a scoliosis up to 50 degrees, 60 degrees, 70 degrees, we know that the correction is mainly done for cosmetic purpose. It's a different scenario. But when you get a patient with rigid scoliosis, and that too a severe form, it's a different ballgame. Because you anticipate lot of problems in a patient with rigid severe scoliosis. For example, the patient may have a poor pulmonary reserve. When you do the pulmonary function test, his FEV1, the vital capacity will be reduced. And if the patient is long-standing with respect to his respiratory problem, he may have problems of pulmonary hypertension. All this complicates his anesthesia part of the surgery, as well as the surgical morbidity and mortality of the surgery. So in a patient with severe rigid scoliosis, there is still a chance that the curve can progress even in the adult. So when a curve progresses even the adult beyond a certain level, there is a chance that the cord or the dura can be stretched to an extent that it can produce a neurological deficit. So managing a rigid scoliosis is a different ballgame when compared with a adolescent idiopathic variety, which is usually less than 60 degrees or 65 degrees. Now, why do we get this kind of rigid scoliosis? One common condition will be an untreated adolescent idiopathic scoliosis where the child or the parents have postponed the treatment to an extent that this has become rigid, very rigid, and very severe. Sometimes children come at the age of, they are looking for a suitable match, and this becomes a problem for them. Usually we get patients at the age of 23, 24, 25 for correction of an easily manageable curve which could have been easily done during the early adolescence of the before adulthood. Sometimes you get patients, though the curve may look typical to, may look like an adolescent idiopathic variety, there may be an underlying intraspinal anomaly. For example, a common one is a syringe or syringomelia. So when you get a very rigid scoliosis and it is fast progressive like this in the second child, this child has become so grotesque, the deformity has become so grotesque in less than 6 months. We were following up this child for last 2 years, thinking that it was adolescent idiopathic scoliosis, but by the time when she became 13 and post-menarche, her curve suddenly progressed, and we were looking for a reason why this curve suddenly progressed and became so rigid and so severe, and we found that the child was having an Arnold-Chiari malformation with a hollow cord syringe. Syndromic varieties of scoliosis like this child with Larsen syndrome, can be quite rigid even from the initial presentation. Other causes of rigid scoliosis could be, even the curve in a congenital scoliosis can be smaller, it can be quite rigid. Neurofibromatous scoliosis can be quite rigid. Marfan's can be quite rigid, and many cases of neuromuscular scoliosis can also be quite rigid. So whenever you're getting an atypical curve in an adolescent idiopathic scoliosis, for example, a left-sided curve or a curve that is much more less flexible, or a curve which has got an atypical pattern, we have to think always in the form of an underlying cause which can make it rigid. Now, when do you call it as a severe rigid curve? It is debatable in the literature, but generally, for classification purpose, we generally take more than 90-degree copes and which is correcting to less than 25% in bending films as a severe rigid curve. Some authors give 30%, less than 30% correction, and greater than 80 degrees of COP. Now, these are various publications from the Asian authors. There are various publications of Asian authors which actually in various all these publications, these are all Asian publications which have defined severe and rigid scoliosis as variable, 90 degrees, 80 degrees, 70 degrees, with the flexibility somewhere in between 30% or 25%. So that is that. So you can take arbitrarily 80 degree, more than 80 degree curves with flexibility less than 25 degrees, 25% as a severe and rigid scoliosis. Now, the question first, when you see a severe curve, is how to assess its severity. Standard, we take the standing coronal curve, and the next one that we usually use for assessing the flexibility is the supine side bending. But in a severe curve, there can be a problem, because when the curve is severe, when you ask the patient to do a supine side bending, the rib hump or the rib prominence will easily come and touch against the pelvis. So there is iliocostal impingement, and as a result, the flexibility of the curve may not be properly assessed. So in that case, you can modify the X-ray that you take by using push-prone films or traction films. The third one, the fulcrum bending films, are the ones that we use in our unit. So there is there is a standard way of taking the fulcrum bending films, and this is how we take the fulcrum bending films. So the fulcrum is kept at the apex of the deformity, and the key thing is that the size of the fulcrum should be in such a way that the pelvis as well as the shoulder should be free to hang down, should not touch the X-ray table just like that. So the patient has to have an effort to make the shoulder and the pelvis to touch up on the X-ray table. And also one has to be very careful in seeing that the pelvis do not fall anteriorly or posteriorly. So otherwise, what happens is the rotation will come in your assessment of the films. So that is a key thing that your radiographer should be trained. You should go and train with your fellows, with your postgraduates or residents, how to take the fulcrum film. Otherwise, the fulcrum film is of no value. Now, what are the goals of surgical treatment of severe scoliosis? First thing is to prevent the worsening and to correct the deformity as much as possible with minimal morbidity. That is, safety is of prime concern in these patients. Second thing is to fuse the shortest possible. So that is with the idea of preserving maximum mobility. So function, to attain the function, is the second important role. The third one is to achieve a well-balanced and less deformed spine, cosmetic. So all these words are important in the goals of surgical treatment. First thing is to prevent worsening. Second is to fuse short as possible. Third only comes the cosmetic part. And when the cosmetic part, the most important terms that I would like to highlight is a balanced spine. So your aim is not to make the X-ray look superb. Your aim is to make the patient balanced so that he has a near normal function with this severe, even though he is having a severe scoliosis. And one should always remember the adage that a child with scoliosis treated is also a child with scoliosis. So there is a difference in the this is very important when you manage rigid scoliosis. Now, the problems that you anticipate in treating a severe rigid scoliosis is you obviously you have longer duration of surgery. If in our setup we use two surgeons operating simultaneously on either side, so this actually shortens the duration of the surgery, and the amount of blood transfusion that we use, the amount of the time that the wound is exposed to the surroundings, all these can be lessened if we use two competent surgeons on either side. Now, in rigid severe scoliosis, whatever surgery you do, if you are doing an anterior surgery, there's a chance for opening up of the pleural cavity or the abdominal cavity, as the need may be. Even if you are doing the posterior surgery, there is a chance that you may inadvertently enter into the pleura or sometimes rarely into the peritoneum. So there is definitely a chance of opening of the pleural and abdominal cavities, which will determine the postoperative management of these patients. Of course, correction of a severe scoliosis is bound with neural deficit, chance of neural deficits in all series. And sometimes these patients will require prior pre-op optimization of chest function, and with the added concern that the patient may require ventilatory support for some time after surgery. So if all these eventualities, you should be prepared for before attempting surgeries on rigid severe scoliosis. And in my opinion, once we started doing in our initial part of our surgeries, we did not have the facility of intraoperative neuro monitoring, so we were using only the wake-up test. But once we started using this intraoperative neuro monitoring, we feel that this is mandatory for correction of severe scoliosis. Now, coming to the outline of the surgical treatment of rigid scoliosis, you can broadly divide the rigid scoliosis correction into two parts. One is the anterior release, and as a step one, and second step going after 2 weeks for posterior correction. Then second type of procedures will be posterior alone single stage. So these procedures examples are Ponte Osteotomy, a posterior vertebral column resection, which is known as the PVCR, or the PS or pedicle subtraction osteotomy. And there is one more procedure which is coming into literature, though it was in vogue for many years. This has come into literature with some papers coming from various parts of the world, particularly Asian journals. This procedure is known as the passive correction. So we will go through one by one. Now, what is the crux of the matter in treatment of rigid scoliosis? There is no doubt. Biomechanically, it has been proven in various papers. I am quoting the latest paper in Spine 2013, that biomechanically it has been proved beyond any sort of doubt that anterior release generates more thoracic rotation than posterior osteotomy. This has been done in all cadaver spines. So definitely anterior release, anterior surgery has a weightage, has an added advantage when compared to posterior surgery alone. That is sure. But if you take literature, this has been again taken from the Indian literature, paper published from Arvind Jaiswal and team, and they followed up these patients with anterior release and posterior correction, where the preoperative Cobb angle was roughly around 116. So after the anterior release and the traction, they found that there is only 30% correction. But after the second stage, after 2 weeks, the posterior instrumentation was able to reduce this 115-degree curve to 25 degrees, which gives nearly 75% degrees of correction, 75% of correction. So this was in vogue for quite a long time. So I just sharing one case from the literature. Here there is a preoperative curve. This is probably a ligament type 2 or a type rigid type of scoliosis, but the two curves measuring over 118 degrees. And after the anterior release, the curve has become, see, after the release curve has become 76 degrees. And after 2 weeks, they went in from posterior and fixed with the pedicle screws, and you got a final correction of 22 degrees, and with a very nice, nice sagittal alignment of the spine. And the clinical photo from this level, where the right shoulder was so high up with a very ugly deformity, the surgeons were able to bring the plumb line to neutral and a very good symmetry of the shoulder and the neck tilt. So that is a fantastic result when compared to where we started off with. I know that many of our teachers, many of our mentors were doing this procedure for a quite long time with very satisfactory results. But there is a downside with this procedure. Most often the problem is the chest related complications. Many of these patients, if you test with PFT during the preoperative period, these patients do have very low pulmonary reserve. And when you open up the chest cavity for doing an anterior release, most of these patients will require when post-operative support. And a little bit of the lower lobe of the lungs will get collapsed, and so they will require aggressive chest physiotherapy in these patients. Ram, hello?
Please go ahead.
Yeah, I can continue, no?
Yeah, please.
Okay. Okay. In that concept, in that context, others have shifted, many surgeons have shifted to why can't we do all these procedures from posterior alone? And this was, so initially they started with minor releases. So the minor releases involved fasciectomy to mobilize little bit of mobility to the rigid segment. Somehow they started doing the concave ribs, they osteotomize the concave ribs. And anyway, mandatory is to remove the ligaments, the supraspinous and the interspinous ligaments. But the results were not great until the formal osteotomies in the spine came into vogue. So few of the classical osteotomies that we perform is the Ponte osteotomy, the asymmetric pedicle subtraction osteotomy, and the vertebral column resection of the VCR. So is there a biomechanical logic in performing a posterior procedure when biomechanically it is proven that anterior release will give a definite more correction in the thoracic rotation? So what is the biomechanical logic? Now, so I will go to the next slide and come back. See, this is the most important concept in doing posterior surgeries for a rigid scoliosis. That is known as IAR, or instantaneous axis of rotation. What it says is that when a body moves, at every instant, there is a line in the body which becomes the center of rotation. So normally what happens in a normal vertebra, which is intact in its posterior elements and the ligaments are intact, generally the center of rotation, or the instantaneous axis of rotation, is generally somewhere in the posterior border of the annulus. But when you weaken up the posterior elements by removing the ligaments, by removing the posterior capsule, by removing the facets, and even removing some of the posterior lamina, what happens is the instantaneous axis of rotation actually shifts more anteriorly to the stiffest portion, that is somewhere in the center of the body. So if you have a device which is able to control the body, control the instantaneous axis of rotation from behind, you will be able to control the rotation of the vertebra from behind. So that is the key of doing a posterior release for a Pontes osteotomy. That is the biomechanical principle behind doing a Pontes osteotomy. So the only device that we have at present where you can hold anterior to the axis of rotation from posterior is a pedicle screw. So the pedicle screws are the key device to do a posterior correction of a rigid scoliosis. This cannot be achieved from a hook or laminar construct because it controls only the posterior element. That is why the initial part of the surgery is when we compared with the CD system, with the correction alone from the posterior, the correction was very dismal. So that is why the focus shifted towards anterior release and posterior correction, where the posterior correction was initially done with the hook and the hook system. So again, but when we converted that hook into the pedicle screw, you were able to achieve near almost similar correction as an anterior release when we were operating posteriorly. So again, the pedicle screw allows rotation without anterior column surgery. So this is what happens. So when the screw, using the screw, you can maneuver this way or that way, and the vertebra will move in the opposite direction. Okay, this is the thing, that the your hook is not able to control the anterior part. Okay, so the pedicle screws have the most favorable biomechanics, better correction. This is a very rigid construct, and you hold all the three columns and with lower reoperation rate when compared to hooks. They dislodge, sometimes cause some more pain. So all these problems are there. And the key thing, what initially others advised was to get a bicortical purchase with the pedicle screw. But when you get a bicortical purchase with a pedicle screw in a deformed spine, your rotatory capacity is much more magnified. But the problem is you risk the injury to the anterior structures. So generally, when with the pedicle screw, so the pedicle screw is a key in doing your posterior procedure. We use the freehand technique where you expose and you curate out the junction of the transverse pose and the lamina. We look for the pedicle blush. Sequentially, we go probe, advance the probe little bit, again probe. Make sure that you are holding on to, you're palpating all the 4 or 5 walls of the, and we replace the screws. We generally do not use CM for this purpose unless for level marking. Then once the pedicle screws are in place, you can have all the various maneuvers that you can do, that you are accustomed to in doing a scoliosis because of the long tab extenders that we have. Then one more thing, what we have noticed is the use of reduction screws at the level of the apex. Reduction screws as well as the monoplanar, uniplanar screws also helps us to get a better correction in the rigid segment of the curve. Then another, the strategy that we use in many of our cases in rigid scoliosis is a traction. This is our setup, how we use the traction. So the patient is on the bolster, and we put the lower femoral pins, Stillman pins, and use the same fracture table that we use for giving traction. And on the head, we apply the skull tongs. The 50% of body weight is divided between the two lower limbs, and counter traction is given as 1/3 of the body weight from the skull. We generally use the horseshoe frame. So this is one case of severe. This is a 24-year-old girl who came because her marriage was not getting fixed because of deformity, and this was operated under traction with posterior releases, and we were able to get this much amount of correction in a very good. See, from where we started, this is the starting, the clinical image of the patient. And this is after 2 months of the surgery. She has got a very much better curve. This is some 5 or 6 years after the surgery. She is actually married now with one child. So with regard to Ponte Osteotomy, it is a sequential removal of certain structures. It is not exactly an osteotomy as such by the term it denotes, but it is the sequential removal of some of the structures. First, you start with the removal of the interspinous, supraspinous ligaments, and we do a little bit of laminotomy on either side, and then we go on to remove the thick ligamentum flavum. Usually, I start from the midline for the removal of the ligamentum flavum and go to either side. The key thing is to remove the ligamentum flavum from the concave side, which is the narrower part. So that is important to remove from there, and complete facetectomy. So once you complete facetectomy, it is difficult to do on the concave side, but you have to do that on the concave side. And when you do it on the concave side, there will be a little bit of epidural bleeding, which you have to control either with Helfom or Surgicel or something like that. So you can do it at multiple levels. We generally have, on an average, do for 4 levels in a rigid scoliosis, but there are cases which we have done 5 to 6 levels. So after every level, so initially before doing the osteotomy itself, I mark the pedicle, I prop the pedicle, but do not put the screws in. Once you put the screw in that level, it is difficult to do a complete osteotomy at that level. But once you complete the Ponte, you put the screw and use the long tab extender. You can just try to move that segment slightly so that we can know whether it is complete or not. It is a very good technique that that will be very useful in most of the cases of rigid scoliosis. So this is how the Ponte osteotomy is going to look like from the lateral view. So now you have removed all the ligaments from here. You have removed the facet from here. So the only thing that is basically remaining is the annulus and the disc. So you are able to rotate the vertebra using the disc as the fulcrum. So here you can see that this is a case of rigid scoliosis where we have put the reduction screws, and these are three levels of Ponte osteotomy which we have made and packed with the gel foam to prevent bleeding into the canal. So to share one case, this another case which is more than 80 degrees of scoliosis, rigid scoliosis. You can see the deformity in the bending films. This is a 12-year-old child. Now, with the sequential Ponte osteotomy, with sequential, you can see that the number of screws that we are putting on this frame, on this case, is much less. We don't have every levels, the screws on every level. Most of them, so our rigid segments, we have more screw definitely, but the other levels are more of scattered. We are able to get a very good correction because the Ponte osteotomies are performed well in this 3 or 4 levels. In this case, 4 levels was performed. And you can see that there is a very good balance of the child of the spine. Now we are all aware of the pedicle subtraction osteotomy. This is what the typical pedicle subtraction osteotomy will look like. So a single pedicle subtraction osteotomy will be able to correct around 30 degrees per pedicle subtraction osteotomy. But this is generally applicable to a patient with kyphosis. But we can modify this pedicle subtraction osteotomy in a scoliosis as well. That is not the asymmetrical pedicle subtraction osteotomy. So in many of these cases, now this is taken from the literature. This is a operated case of degenerative scoliosis. Rather, I think it's a degenerative scoliosis. Now it has the curve has again recurred, and there is a D12 pedicle subtraction osteotomy has been done with an asymmetric component as well, and with that the surgeon has extended the fusion to higher levels, and you are able to get a very good alignment of the spine. But pedicle subtraction osteotomy, definitely there is a chance of a neural deficit in these patients. And also, if you are not able to get a proper apposition of the pedicles of the upper and lower segment, there's chances that this will go into non-union, and also the non-union will result in a failure of the implant. So pedicle subtraction is not an undertaking that have to be taken lightly, and it is always better to do the PSO somewhere level below the corners, so for safety. Now, in very severe and rigid scoliosis, sometimes your releases and PSO may not give a satisfactory correction. That is when you have to resect a part of the vertebral column. The initial series has come from Suk, and he has reported 16 cases. But of these 16 cases, you look at the amount of blood loss that these children are having. And in the Indian setup, these children will be very undernourished. Most of them will be having weights from 30 to 40 kilos. I have a child now who is with the severe rigid scoliosis. His weight is only 22 kilos, and I need to have at least 30 or 35 kilos for a satisfactory safe phase completion of the procedure. So even in the 16 case initially reported by Suk, there were significant numbers of paralysis and hemothorax. So this is a major undertaking that you are doing in this undernourished children. And but definitely this will give very good correction, because you can get 40 degrees of correction per vertebra resected. So you don't go for multiple resections of vertebra. The maximum that I have done is 1.5 level of vertebra in my entire series, but that will give very good correction. And some German group have even given 55 degrees of correction per PCR. So So the approach is so, but one advantage with the in scoliosis when doing a PVCR is the scoliotic part of the curve is easier to the convex part of the curve is easier to approach when compared when we are doing the same PVCR when we are doing for a tumor and all. It is sometimes difficult from either side to get a good tumor clearance. But in a PVCR, there is one advantage is that the convex part of the curve will be rotated towards you. So the convex, so that when you start, if you are able to start the procedure on the initial on the convex side, it is easier and much more easier when after you have done few cases and in some cases where we are planning VCR, in addition to the 3D CT that we take, I do a 3D print of of the spine and take it with me for the operation. I hang it in the in a sterile cover in my operation table over my operation table, and so that I can easily look at and rotate and see where exactly I have to go in, and also this helps me to put the screws correctly, because we do not, because I have felt that I don't have a navigation in my institute. I have felt that when using CR, it is more confusing to know which are the correct position of the screws. Now, from literature, this is a case from literature where they have done anterior correction as well as the posterior release, as the anterior resection as well as the posterior release. The second one is a posterior vertebral column resection alone. So then they have found that they have compared. See, the correction basis is very comparable. With 29 degrees and 25 degrees, it has come. So anterior and posterior vertebral column resections have comparable outcomes, but complications are more with the anterior resection. So this is one case where you have done a complete posterior vertebral column resection, and you can see that once you have done a posterior complete PVCR, you will be able to pass a gauze from one end to the other, and you can see that it is complete. And then the defect is reconstructed with a cage. At the cage, we fill it up with the rib grafts that we take when you are doing a costoplasty. So most of the rigid scoliosis will require costoplasty, and that is a very useful procedure for bringing for giving a better cosmetic outcome. So the generally we take 3 ribs, sometimes 4 ribs. Beyond that, we generally do not take. But there are literature which says that up to six ribs can be resected. Generally, our average is 3 to 4, and that rib gives excellent graft for filling up the anterior cage as well as the posterior fusion. So that's what I was talking about. Thoracoplasty, the costoplasty. A judicious costoplasty saves saves the day in many of these patients. So I'll go through a few illustrative cases to explain what I have so far described. So this is a case. This is a case which we recently operated, and this child is 14 years old, and you can see that this is severe and quite rigid scoliosis. Unfortunately, she does not have any intraspinal anomaly. We screened everything. She does not have any other secondary causes for scoliosis for rigidity. And so this patient, actually we put her on halo gravity traction, and this was our plan, halo gravity. And then this is the 4 weeks in traction with the halo. So we just we have made a wheelchair, and the halo is applied. We have modified the wheelchair, and we apply the halo onto the head, and the child will sit in the wheelchair and will mobilize on the wheelchair. And in between, when she wants to take a nap or something, she will come out of the chair and will lie on the bed with head supported. So initial 1 week for the patient, it's a little bit difficult, but after that, most of the children will cooperate with the halo gravity, and this is the then after 4 weeks we went on to do the surgery by sequential Pontes, and we used the reduction screws in the apical level, and our maneuver of reduction was derotation and cantilevering. So and this is the cosmetic result after the surgery. After the after the sutures were out, she has got a very good correction when compared to what she started with initially. Now another case, this is shared by my friend Dr. Vinod from Calicut. Now you can see this is a very severe scoliosis, very severe scoliosis, which is measuring around 130 degrees. 130 degrees. You can see there is no alignment between the head and the pelvis. And this child again was put on traction, halo traction, and he was put on halo traction for around 2 months, and the sequential X-rays were taken. And then once the curve showed some pliability in the halo traction, we went in with the idea of doing multiple releases and posterior pedicle screws, and the curve was corrected. And this is the from where we started initially to where we are now. So this is an extent from D2 to L4. D2 to L4 was instrumented, and this is how the nice balance is attained. Now another child, syndromic child. This is a child of Larsen syndrome, and actually she is a very intelligent. She is a actually is a boy, 14-year-old child, very intelligent. Actually, her hips were both dislocated. His hips were both dislocated. Elbow is dislocated. Hips we did surgery to put them in 2 years back. I think 2 years back. So then we proceed on to the scoliosis correction. So this is a child with halo gravity traction. This is a wheelchair that we have designed, and this is the deformity in traction. After some weeks of traction, it is much lesser. Then we went on to do the surgery, and the problem why he went on to surgery was he was not able to sit in a chair. He's a good intelligent child. He likes to reading, and the book that he reads are Kalidosa, his Kite Runner, and those kind of stuff. So he wanted to have a peaceful sitting. So we were able to do the surgery and give him that what he required. Now another case of a severe scoliosis, another 14 years. This case you can see that every level is instrumented. Every level is instrumented because even after doing the Ponte, we felt that the correction was not getting satisfactory. So this is from D3 to L4. So all the levels are instrumented to attain a nice, stable, balanced curve. Now, this is another challenging case that we had to deal with. Now, this is a very severe congenital scoliosis case. Why the congenital? This actually child is only 12 years now. The child we have been following from the age of 9 years. Actually, what happened was from 10, 11 years, the curve progressed severely. And the problem is that the patient has got multiple anomalies in his spine. Some of the areas in the thoracic area is fused. Here the L4, L5, this region is fused, and there is a huge spina bifida also. And added on top of that, there is a fixed pelvic obliquity that you can see from this X-ray. His hips are in, but the pelvic obliquity is fixed. The reason for the pelvic obliquity could not be due to the scoliosis curve, because his limb on the left side is actually shorter, congenitally short by 3 centimeters. So this, and the progression of this curve was also quite quick. So how to plan for this case was a challenge for us. Now if we attain, then when to plan also was a challenge, because the child is only 12 years with the opening of the thyroid cartilage and all. But there is no question of performing a growth road in this case, because there are no angles to put, and we will not know what we are going to achieve in this case. So again, because the fusion, the growth potential is also not very sure in this case. So after a lot of deliberations, we decided that we do one procedure that will be good for the patient, not go for multiple procedures like growing rod and all. So so one more point that we had to consider was that if we do a more severe correction of this curve, he will lose this pelvic obliquity, and what will happen is his limb will become much shorter. So the child who was ambulating might become a less ambulator, which will compound the problem for us. So our plan was something like this. We plan to do an L2 particular asymmetric PSO that is below the corners, so that lesser chance of neurology. The insemination was planned from D10 to L5. Don't want to include the pelvis in this construct, but we had to maintain this limb-length discrepancy to somewhere around 2 centimeters. So that was the key. Then some of the pedicles were quite underdeveloped. So the in the convex side, just pre-operative just planned that we'll put extrapedicular screws, extrapedicular candidate screws. And since you are putting the extrapedicular screws, it will not have the same leverage as that of a pedicular screw. In the so the convex side was only used for pushing, not for pulling. Then we did a complete posterior release, asymmetric PSO, and the care was to not to correct the pelvic obliquity as a whole. So, and this is the final result that is obtained. It is a very well balanced spine. Then another case which I want to share is a 11-year-old child, which is the curve is much smaller, but it is very rigid. And the thing is that 3 of the ribs here are actually intracanalicular. So if you try to correct this, there is always a chance that the intercanalicular ribs will rub against the dura and produce a neurological deficit. So the intercanalicular ribs had to be excised first, the first step. So the 3 ribs were, there are few literature reports, actually very less number of literature reports of intracanalicular excision of the ribs. And so we went in with the initial plan to excise the ribs. Once the ribs were excised and did have some amount of releaser, you can see the beautiful correction that you are able to obtain. And so many segments we are able to leave down for the, even though it's 11-year-old child, the fusion will not affect his growth. Now, lastly, we have to discuss about the passive correction. Now, passive correction is nothing but in every rigid curve, there should be a compensatory curve above and below. Sometimes the nature will allow the compensatory curves to help the surgeon. So here, now look at this girl. She's come around 16 years with a severe deformity, and she is not a case of adolescent idiopathy. She has got multiple congenital anomalies in the spine. Some of her the thoracic vertebra really are fused. Some of the ribs are also fused, and so there is a limit to what we can do in a normal way. Here in this case, what we have done is we have assessed her compensatory curves, and we tried to, so we took the rigid segment as a whole and tried to translate that curve into the central plumb line by using adequate placement of the screws and do a formal thorough fusion. And you can see the nice balance and correction that was obtained. So you should, in order to conclude, the idea of doing a rigid severe scoliosis is not to show your heroism, but is to keep it simple. And the idea is to restore the coronal balance as well as, if possible, as maximal possible sagittal balance. Because sometimes sagittal balance is very difficult to correct in this rigid congenital type of scoliosis, because you cannot predict what you are given with. You have to play around with what type of pitch that you have. Sometimes if you have batting pitch, you'll be able to do very well. Sometimes if you're a batsman and you're having a very rugged pitch, you will have to adjust and play accordingly. The balance of risk versus the outcome. Improve the pulmonary function is a very important step why we are undertaking this surgery. Sometimes this surgery is life-saving for many of these patients. Just because a procedure can be done doesn't mean that it should be done. That is my conclusion. These are some of my references that I have used for making this presentation. And concluding, Ram.
Yeah, Dr. Shiju, thanks a lot. So, what I do, I invite Dr. Vishnu. Dr. Vishnu is with us. Friends.
Ram, can we go for a case discussion, or can we have some questions for him?
Yeah, some questions are there. You can even ask him. And one question that came up in chat is, Dr. Shiju.
Yeah.
Questions the people is asking is, when do you prefer to give a hollow traction?
Yes. Now, see the halo traction. See, any case of rigid scoliosis, if the bending frame is not coming, suppose you have 100 degrees of scoliosis, 100 degrees of scoliosis, and your fulcrum frames and all is just coming around only 70 degrees. Now, these patients, they will do very well once you give a halo traction. Actually, halo traction will make the surgery more easy, more comfortable for the patient and the anesthetist. It is something we need to employ much more in our practice. it is not a 3 weeks or 4 weeks of halo traction will make the surgery easier in these patients.
So predominantly you want to say it is a rigid scoliosis which you want to do.
Rigid scoliosis. Rigid scoliosis.
Dr. Vishnu, you want to add up something?
Yes, yes, definitely. Because Dr. Shiju, a very good presentation. Yeah. Should the decision to whether put halo traction or not also depend upon the pulmonary function test?
Yes. Yes. Sometimes we see that patients with this rigid scoliosis, they have very poor pulmonary function in the initial assessment. These patients, once you put the traction, the pulmonary function generally will improve, and to an extent that we can do a safe surgery.
Yes. Second thing, yes, I got the point.
Yeah.
Yes.
Yeah, there is a Vishnu.
Somebody's playing some nice music.
Dr. Vishnu. I think Dr. Vishnu's network is he washed? Is there any piano with him? Is there any piano with him?
No. I don't know how to play piano.
I don't know from whom his voice.
Yeah, maybe some security issue with the Zoom.
No, I think it's gone now. Yeah, before going ahead, we'll take a question from Frank Girba. Dr. Girba.
Sir, do you have any incidents of duodenal tears or anything while correcting the scoliosis?
Yes, very good question, sir. Actually, we had one patient in my, actually it was not a duodenal tear, it was mesenteric artery ischemia. Mesenteric artery ischemia. We, as the one that we learned in cast syndrome, when we apply plaster and all, sometimes people have this superior mesenteric artery ischemia. But how they present with is very interesting. Now this child was he was okay in the ICU for the first day. Second day he started multiple episodes of vomiting, and the multiple episodes of vomiting. Initially we thought that everybody thinks that it is something with the gastritis, drugs and all, but this vomiting was not subsided. And then some color change, bilious type of vomiting also happened. And then we thought that yes, there is some problem in the abdomen. We did a CT, and CT showed some ischemic changes in the duodenum. So he was put on the right tube decompression, and we waited with parenteral fluids, and finally this child, actually it was a lady, settled by 5 days or 6 days. So most of the others also in these cases they advise conservative or expectant management. Usually they will settle, but there's a problem that we'll have to anticipate in these patients.
Thank you, doctor.
Thank you.
See, some more questions coming up is Dr. Barney. What will be the X-ray protocol for Dr. Vishnu, you're using any piano or what? Dr. Shiju, the question to you, what will be the X-ray protocol for halotractions?
X-ray protocol in the sense, do you mean pre?
How many X-rays you do? How long will you keep the halotraction? That's the.
Like that. Okay. Actually, when we put the halo, before putting the halo, we take a CT of the head. That is important, because sometimes the children will have anomalies in the deploy, and your pin might be going into some sinus, frontal sinus or something, and it will cause infection. So that's the first thing. You do a screening CT of the bone window screening CT of the head, And after putting the CT or the pin also, we do a repeat scout CT. So know that the pins are perfect, and because we are going to leave this child to home at times with the traction, so we need to know that things are perfect. Pakka. Then generally the X-ray is taken every week. Every week after putting the traction, the X-ray is just a PA view, no bending or anything, just a traction PA view. And usually, if it is coming, usually you will see the changes by the second week. Second week you can see that the curve is becoming much better. So if the curve is becoming better, we continue the traction for 4 weeks, and this will give a pliability of the curve, pliability, because we are not doing any distraction or the child's weight alone is actually acting as the counter force, counter traction. So by 3-4 weeks we take a decision. Usually the child will go to surgery by 4 weeks. There are some cases which we have done at 6 weeks, but generally by 6 weeks they become tired of this traction.
And anytime you want to see, the pins also comes out, right, in between.
In between, yes, that's but that's why once you start doing the CT, that incidence will come down, because you will adjust it the next day itself. If there is a suboptimal pin placement, you will adjust it the next day itself. Because if the pins start coming out, the problem is the child and parents will become uncooperative to this mode. So we have to see that the pins are vakka in its place. Maybe first week it's difficult for the children, because more than the children, the parents will be more anxious. So we have to put them on track. So that's very important. Otherwise, they will give you sleepless nights with the child interaction.
And one more question was, how do you check this spinal balance intraoperatively?
How do you check the spinal balance?
Introp. The patient being
Introp,
yeah.
The technique that we use is the rod. We have the T-rod, T-shaped rod, which we just keep over the pelvis and on the two iliacus. And the longitudinal part of the rod will be ideally should be within a few centimeters on either side of the C7 plumb line. So of the C7 center of the C7. So if it is in the center, it's a very good balance. So that way we can, crossbar. That is a crossbar, or the modified crossbar that we have made, or even if an orthopedic surgeon, you can have the reamer of the canal reamer, which is actually good. Canal reamer, the manual reamer that you have, canal reamer. So it's a T-shaped. It's a long T-shape. So from 40-45 centimeters long it is. So you can keep the T portion, the horizontal portion on the pelvis, and then the longitudinal portion will be your plumb line.
So quickly, what we'll do, Dr. Vishnu.
Yeah, Ram. Can I share my screen?
Yeah. We'll quickly share
for that. Yes.
And then we'll have a small discussion.
Okay. For that, Dr. Shiju has to unshare this thing.
Once again, I'll do that for you. Yeah, now we can do. Vishnu, you can go ahead. Vishnu can, Dr. Prince also can join. Dr. Vishnu will show his cases. What will be the choice of management? Then we'll discuss. Yeah.
Able to see my screen, Ram?
Yes.
Okay. So first case I want to show is 18-year-old girl with rigid congenital scoliosis, left-sided. You can see that right side ribcage is totally collapsed. The left side thoracic rigid scoliosis. So this is the X-ray picture. You can see there is multiple congenital anomalies at the thoracolumbar junction. With almost, it was around 120-degree curve. Am I audible, Ram?
Yeah, you are audible.
Okay. So the main problem with this patient was severe respiratory dysfunction. The forced vital capacity percentage at the time of presentation was less than 40%. The patient was not able to speak a few sentences continuously, and the patient was having breathlessness on speaking. So with this, we had taken a traction film with less than 10% of correction. I was not having it at present. So this is a CT scan, and this is the X-ray presentation. So what will be your mode of treatment in these kind of patients? Rigid scoliosis with severe pulmonary dysfunction.
Yeah, Shiju.
Yes, Ram, hello.
Yeah, you can comment and then you give your option and then.
Yeah, what about the MR of this patient?
So MRI picture, there was no cord anomalies was there.
Okay.
No cord anomaly.
Okay. This the fused portion is somewhere here, no?
Yes.
In the mid,
You can just the convex part of the apical region.
The ribs also, is there a fusion in the ribs also?
Yeah, definitely. Ribs were not fused. You can see the 3D reconstruction.
Yes, yes.
The ribs were not fused.
Yeah, yes, yes. So in this case, I will definitely start with giving a halo.
Okay.
Giving a halo, and also I will do a 3D printing of vertebra here. Because I have the facility to do that, I will be doing this because that will give me a good orientation of further planning in this case. Of course, the 3D
Okay, well,
CT is,
actually, I wanted to have that question. So, what is the 3D model? How do you get it done, and where do you get it done, Dr. Shiju?
Yeah. See, this is there is a government-sponsored program in our hospital where we
Okay.
are collaborating with the engineers on CAD modeling. So that is not expensive for us. Otherwise, it's expensive. It is expensive.
Okay.
We need to pay only the amount of this acrylic material that is required for building this 3D model. So the amount,
Okay.
how many grams it is required, that amount only we need to pay. The modeling and everything will be done free of cost.
Okay. Okay.
Free of cost. So, but that's a very good technique because that gives, you can hold that whole spine in your hand and rotate and see what is the structural anomaly and all. Like when you're rotating the 3D CT in the computer, you can rotate, no?
Yes. So they will give they will give the whole spine or just the curve involved.
No, whatever. If you don't want the upper part and all, that your expense will be less. But
Okay.
this case, it is better to have the whole spine right from this portion to the sacrum because
Okay.
this is 180-degree turned, no?
Yes.
180-degree turned. But this gives a very, even the operation table. If you hang it in your table, you will be able to look all around the spine. Like that gives a different feeling when you are operating.
Yes. Okay. So we followed the same thing. So we applied a halo traction here. You can see that.
Prince, you want to add up something?
Yeah. Good evening, Ram.
Yeah.
Shiju, that was a very good presentation. Thank you for that.
Thank you.
Looking at this rigid curve, I don't have any experience on halo gravity traction, but I've seen some traction on the wards. What we used to do is we used to put them on tongs and femoral pins, like traction, how Shiji showed in the intraoperative image on table. Same thing we'll put in the wards and then maintain for about 4 weeks. And we can see the progressive x-rays in a week time and 2 weeks time, how much it unfolds. Usually this is to get out that impingement caused by the ribs on the pelvis. So that itself will tell you whether you can put 1 finger or 2 finger or 3 finger. Clinically itself will know how much you can get into that impingement. Actually traction works and it helps you intraoperatively also. So we use that. And looking at this, it's a very rigid curve and I won't expect more than 60% correction in this All I want to get is this into the safe balance that is in between the SI joints. If I'm able to bring the curve, then I will be happy with this. So I think this will require a front and back. That's what I'm thinking. Going on the bed of ninth rib, go and release the 9, 10, 10, 11, and 11, 12, and then get back after say a week's time with the same traction, and then come back and do the posterior Pontes and do whatever, how much ever correction. And I may not go for a VCR in this. That's my opinion, Ram. I think.
So basically, you opt for a
Why
front and
can I just know why Prince?
Yeah, Vishnu. Yes. Yeah.
So why you are against VCR in this case?
No, it's just the morbidity of the procedure and the blood loss, and so I think even anterior surgery, I think it's morbid, but we are not doing a bony work. What we do is we just do a complete release of the disc. It's not just cutting the annulus and using a curette and coming out. We have to really shave off the entire disc to get this correction. So if you get 3 discs out, I think the correction you will get is phenomenal from posterior Pontes at the from whatever I have seen. I think anterior and posterior staged is better than one staged VCR, PVCR. That's what I think.
PVC.
That's my
Okay.
reason.
Okay. Thank you.
Yeah.
Thank you, Prince. Okay. Actually, we Ram, do you want to add something else?
No, please go ahead, sir.
Okay. So actually, we since our major worry was the patient was having respiratory problems, so we put her on halo traction. So we also mobilized with the walker. The patient can walk with the walker, and patient can sit with the halo traction on. So we gradually increased the halo traction. We kept her in the hospital for a week's time, discharged her, and the halo traction was continued for another 3 weeks. Total 4 weeks of halo traction was given. Okay, this is what how they practice halo traction in the house. So this was the correction we got. You can see that the right side lung, which was totally collapsed, it broadened out.
Yeah,
and usually the way we measure the correction is what is the height gained. So how much height the patient has gained every day. So we used to measure that. So after 4 weeks, we thought that the pulmonary function also improved. The nutrition we were also give nutrition supplements were also given. Then we thought that patient is ready for the surgery. We also thought of whether we can go anterior, but the anesthetists were a little bit worried that the pulmonary function, even though it has improved, there was not much of improvement. There was only mild improvement was there. So we thought of not going anteriorly.
Yeah.
What we did we did a
Dr. Vishnu,
we did a PVCR at the Ram.
How many is that the pins never came out for the last one month, or is there any changes that you did because of infection? It pulled out during the 1 month period
with the pins.
With the pins.
Oh no, actually, I got a new idea that we have to take a post CT scan to check the level spin. We have not done that. Usually, we did a finger tightening of the pins. We usually keep the patients for 1 week time. The patient is having any problem, we used to alter that pins during the stay. So if there is no problem with the pins after 7 days, it's highly unlikely that patient will develop pin side problems, like loosening and all those things. So we always ask the patient with a little bit check the tightening of the pin with the fingers, just fingers. They can tighten by themselves.
Because what I did for one case was it became loosened, and there was one thunder that happened during the stay at the girl's house. So she suddenly felt jerky, and then out of fear that she moved suddenly. And pins from the skull. But as such, it didn't traumatize her. And that was one incident that happened. That's why I was repeating that.
So usually weight. In this case, we initially at the start of this we started with around 6 kg, 5 kg, and gradually we increased up to this patient was weighing around 40 kg.
Okay.
As said, we increased up to 12 kgs. That was 1/3 of the weight.
Okay.
So when the patient is lying down, most of the time patient will be lying down. So we used to elevate the head end so that the body weight acts as a counter traction.
Please go ahead. What is
Take
that?
it. Okay. So after 1 month of halotraction, we did a posterior vertebral column resection at the apex, followed by posterior instrumented correction. So we also did a Ponte Osteotomy above and below that PVCR level. The one problem we had during the this correction was we were not able to stabilize and correct using a single rod. So we used 2 rods. So one set of rods separately for closing that PVCR segment, another set of rods to correct the proximal and distal curves. So we got a reasonably good correction. So this was a clinical picture you can see. But patient, even though the patient had 1 month of halotraction and improved pulmonary function, patient needed almost 36 hours of ventilatory support following surgery.
Chest tube as well.
Huh?
Chest tube.
Yeah. Did you put on any thoracic chest tube for the patient?
Yes. You can see that.
Okay.
You can see that
Yeah.
the post-op X-ray. Because when we did a rib excision, the pleura was opened up. So we thought, why to take risk? We inserted tubes on either side.
Okay. So which rods were closed first? You closed the VCR one first
Yes.
before
Yes.
getting the correct. Okay.
Yes. We did the VCR one
So-
first, then followed by the long rods.
Okay. So you didn't.
Actually, we didn't go with that plan. Actually,
Okay. Yeah. Understood. You can't connect the rod to the.
yes. I
screw
tried
heads.
it, and then I remember in Ganga operative course, one surgeon was doing like that. Then I tried this one, and we came out.
Okay. Did you
Good
need
idea,
to connect
actually.
the rods, or you just left
Yeah.
the rods
It
independently?
looks like a cross link.
See, the crosslink. We used crosslink only for the longer construct.
Okay. So there's no connection between these rods.
No. So what actually I'm not well aware of these methods. So do you think there should be an interconnection between these 2 rods that D through seg constructs?
No, to be honest, I don't have any experience of doing this one.
Okay.
Others can answer, Ram or.
Yeah, I think I
Shiju.
did one where I connected the shorter rod with the longer rod.
Okay.
Your short cross connector, whichever I'm seeing in X-ray, I thought suddenly was connecting the shorter construct with the longer construct.
No. It was just connecting the 2 longer rods.
I think we can do that. Okay?
We can do that. We can do that. Just to increase the stability.
Shiju, you want to add up?
Yeah. There's a comment I have to make. Actually, it's a very good correction, very good surgery that you have done. There are few things which I would like to add. One is, hello?
Yeah, we are hearing you.
Yeah. See, what you have now done is you have done a VCR.
Yes.
Stabilize that segment.
Yes.
And what you have done is you have actually used the compensatory capacity of the compensatory curves.
Yes.
The upper and lower curves. You have used the ability to compensate onto the longer rod.
Yeah.
Because the mid segment is still rigid, but you have done a weakening of that rigid segment by doing the PVCR.
Yes.
So that is exactly the concept of passive correction. So you have combined the passive correction with the PVCR now. So even if you do an anterior surgery, you may not be able to achieve this much. Anterior surgery, anterior release, and this may be the final X-ray also, and the added risk of a ventilatory problem.
Okay.
The PVCR that part we may require crosslinks connector, because anyway you are weakening the anterior part. The crosslinks will be advisable in that area also.
Okay.
But this is a good thing that you have chosen to because sometimes it is very difficult to get the single rod onto the PVCR part.
Yes, yes. We actually it was a long surgery and we were fed up.
Yeah, I have an experience with one case almost like this. So we didn't have the idea of pre-operative plan. There was no idea of putting two rods, four rods like that. We tried saying a
Okay.
different ways how to connect. Actually, in that case, we were using the USS2 system. USS2 system, actually, if you have experience, it's a very robust system and works with translation.
Oh
By,
yes, yes.
by translation, and most of the curves, if you will be able to somehow attach onto the rod, the screw onto the rod somehow.
Okay.
The other system, the top loading and all, sometimes you will struggle. The USS2, if you are regularly using that system, it is you'll be able to attach it somehow. But in that case, it's still the USS2. It's also it was very difficult. So then we put two. Actually, we got hold of two vertebrae above and below of the PVCR part, and then what we did, a long rod like this, and connected the transverse connector between the long rod and the short rod, like a four rod system, four rod linkage.
Okay. Okay.
So that was how we bailed out in the situation. Actually, that child is doing well. Some 4 or 5 years after surgery, actually
Okay.
it is a case of spondyloepiphyseal dysplasia. So
Oh,
her hips and the congenital anomalies were there, spondyloepiphyseal dysplasia, and more of a kyphoscoliosis. So sometimes we have to think out of the box.
definitely. Okay. Ram, if there is anything to add, or shall we move on to the next case?
Please go ahead. Now, one case which I learned from this technique from you. Before that, I did one case. The screws pulled off. It was like apex. You tried so much. The
Okay.
so, but I think this option is a very good option.
So
Yeah.
you stopped at L4, Vishnu?
Yeah, Prince.
Okay.
I thought it was balanced. So just
Yeah, it's good to at least leave two discs and see how it behaves.
yes.
I would have done the same thing, stopping at
So
L4.
this was the clinical picture.
Hmm.
Now almost 2 years follow up. The patient is doing well. So I will go on to the next case.
Okay.
Yeah.
So this was a case again a young school going girl with an a rigid proximal thoracic curve. So the patient was having segmentation anomalies from T4 to T9 level. So the patient was having segmentation anomalies from T4 to T11 level, and the ribs were all fused on the convex side. So in this case, the patient, the curve was rigid, but pulmonary function was reasonably okay. If I'm correct, the FEVC was around 70%, and the patient was not having any breathlessness, and breath holding spell was also longer. So the patient was not having any respiratory problem, but a rigid proximal thoracic curve. So in this, with segmentation anomalies, multiple segmentation anomalies, not exactly a hemivertebra type, just a segmentation anomaly was there with fused ribs. Sorry, I couldn't provide you the CT scan. I know the CT scan will go a longer way in deciding what kind of surgery to do. But with this, so what will be your plan,
And
Prince?
Yeah, here I would hesitate to go anteriorly because it's more proximal thoracic, getting into the
Okay,
even see D below D9. I would think of doing an anterior release, but here it is more proximal than that, so I would do only a posterior surgery for her. Anyway, I'll consider traction, definitely being a rigid curve. I will have her on traction. Do you see that fold there unfolding? I will see how much she unfolds, and then do a single staged posterior only. With probably I will do a multiple Pontes, maybe 5 or 6 levels, and then try getting the curve almost like say 60 or 70%. I may not get 100% correction. I'll definitely consider costoplasty in her, like 4 ribs.
Okay.
That's
Okay,
what I
that
would.
will give a good cosmetic this thing.
Yeah.
Okay. Dr. Shiju?
Yeah, plan is similar. Plan is similar to Dr. Prince's, but I will be interested in holding the proximal thoracic curve in this patient. Because somewhere my upper level will be D2. D2 should be my upper level, and on the I think this case is much more easier than compared to the first case.
Yes, previous, definitely,
Yeah,
definitely.
yeah, we will be able to do
Okay,
get a
actually,
balance.
yes, yes. So actually, in this case, what was worrying was there was a lot of segmentation anomalies. So there was no disk space in between, almost for the 4 or 5 segments,
Yes.
and there was a fused convex fused rib was there, almost like an bar. So we thought that even if you are going posteriorly, since there is no disk space in between the almost from T4 to T8 level, even though if you do a Ponte Osteotomy, it is not going to correct. So what we thought was we will go anteriorly. So we just created a disk space like thing. So there was a rudimentary disk space was there. We just using the osteotome, we created disk space. We released anteriorly. So we
What level was this?
So it was the apex was around D6 level.
Okay.
So at the level of D6 we opened up and we were able to create disk spaces 2 levels below and 2 levels above.
Okay.
So the absence of disk spaces and reasonably good pulmonary function prompted us to go for an anterior surgery. So we did anterior release followed by a posterior correction, and we didn't get a very good correction. But the most of the cosmetic correction we got was because of costoplasty, and you can see here in the thoracolumbar junction the pedicles were all very dysplastic. So we have to use sublaminar wires for that. But we got a reasonably good correction with the balance.
Okay.
I went from left side.
Yes.
Okay.
Hello.
You are fused on the right side, right, sir? And you did a cross from it.
Yes, actually, the ribs for the fused ribs, we were able to release that fused ribs from posterior approach only.
The
So
disk
through
spaces.
yes. So the disk space, we just wanted to create a disk space where only rudimentary disk spaces, and we are fused on the convex side. So we concave side. So we entered through the convex side. There was some mild disk space there, through which we were able to put the osteotome, and we opened up on the opposite side also.
Through and through. Okay. Okay.
So any more points to be added to this case?
Yeah, Dr. Vishnu.
Yeah, Dr. Shiju.
A few questions I have to ask. How
Yes.
was your screws on the are mainly on the convex side, no?
Yes.
Mainly on the convex side. Your concave side, basically, there are no screws at the rigid part of the curve.
Definitely. Yes.
Yes. What I was asking, what was the pedicle? How is the pedicle on the concave side? How was the pedicle on the concave side, like in the apex near the periapical area?
Periapical area, it was all dysplastic. We tried putting it. Actually, CT scan was showing that the pedicles were dysplastic. We were ready for that, and at that level of service, it was very rudimentary and dysplastic. We were not able to put even 4.5 mm screws. So we didn't. We tried it, but since it was blowing out, we just left it like that, and we used the sublaminar wires.
Okay.
So mainly the yes.
What's the time? What's the time interval between the anterior surgery and the posterior?
Single stage. It was single stage.
Single stage. Okay.
We did anterior followed by just a prone. We position the patient in the prone position. We did a posterior on the same day. So that the anterior release was reason for the little bit of correction we got it here.
How long it took?
Yeah, Ram.
How long it took, sir? Surgical.
It took around 10 hours.
10 hours. 10 to 11.
Yes, 10 to 11 hours. to be frank. Because we have to close that, again repositioning and again opening. So it took a quite significant amount of time for us.
So when you are doing this surgery,
Yes.
it's a personal question. So once you have done
Yes.
the anterior, did you feel that the job of anterior is done, or you felt, man, I should have done only posterior?
Exactly. That's a very good question. Because when we did anterior surgery, anterior release,
Okay.
the amount of release, the mobility, what we would have was not very good. So usually, if you're doing severe adolescent idiopathic scoliosis, you're doing a discectomy. We just in some cases, I used to try to put this spacer. We use in Telefna, the spacer I used to put in between the bodies and used to rotate to see the movement of the vertebral body, how we have released. So in this case, literally the movement was not very good. Even though we were able to see that create a disc space, we are not satisfied. But when we turn the patient posterior, when we release that convex ribs, it was all fused together, clumped together. When we release that, we are able to attain some movement.
So was it because of your release from front, or is it because of release from the ribs?
Both. So our rib excision from the posterior aspect and creating a disc space through anterior approach both helped in the movement.
Because one case I do remember, but not the scoli, it was a kyphosis. It's a fusion defect anteriorly, and because of which the cord was stretched, it was draped over it's like a gibbous. So Dr. Satish, my mentor, did anterior release.
Okay.
10 level, D6 to 8 levels. Then I went behind and then fused from behind. Then when he was doing anterior release, I was thinking it was not moving at all. It was not, I felt it is not going to help me posteriorly. But when I went posterior, I found some advantage, but it may not be that great. So that's why I asked you this question: whether should we have done only posterior that would have sufficed, or does really the question?
Definitely. See, for example, so through the apex and the periapical region are fused anteriorly. So unless otherwise we would have done a vertebral column resection, we don't have got some sort of release correction in this case. So we thought that creating a disc space anteriorly helped us a lot in this case.
So Dr. Shiju, the question has been constantly asked. Some people, you just elaborate about this passive correction, which this is like passive correction.
See, imagine that you have a rigid segment of scoliosis. There is a portion that is above and below the scoliosis which is mobile. That part is clear, no? That part is clear.
Yes, please go ahead.
Yeah. So when you take a bending films, it is the rigid segment will remain rigid, and the compensatory part is actually the one that is going to move in a rigid scoliosis. So the idea of doing the rigid scoliosis, the correction of a scoliosis, is to balance the spine, not to make the rigid segment straight. So your C7 has to be somewhere balanced between the sacroiliac joint. So carefully plan. In some cases where the rigid scoliosis is not rigid part of the scoliosis is not amenable to putting screws. For example, dysplastic pedicles are there, or fused together and they're not segmented. So there is no point in putting screws there and trying to make a correction, because that correction will not happen. But you can manipulate the concentric curves in such a way that the whole of the spine becomes balanced. The rigid portion will remain as such, but the compensatory portion you will be able to correct almost like a pseudo correction. But ultimately, your line of the C7 and the sacrum will come in a single line. So that is useful in some cases where you need not spend your time and energy and risk the rigid part. The rigid part alone, if you are able to put a little bit of implant, that will translate towards the midline. But you correct with the help of the compensatory curves, you correct with the instrumentation. The ultimate result will be a well-balanced spine clinically. Though in the X-ray, the rigid part of the scoliosis will remain as such. So that is the concept of passive correction. They are passively correcting the compensatory curves and making use of the compensatory ability of the body as well as the instrument. So that is very useful in cases where lot of congenital anomalies are there, where there is no other option possible. For example, even if you are not possible, it is not possible to do multiple level PVCs safely. You can do PVCs 1 level, 2 level, but if you go to multiple levels, patient will there's a high chance for neural deficit and losing the
Definitely.
patient also. So in such cases, don't think about the X-ray alone. Think about the patient. Patient has come to you with a clinically appreciable deformity. What she wants is a balanced shoulder, balanced head and spine. It is not the X-ray that she wants, he or she wants. So think judiciously. The only see, there are limitations to your surgery in a rigid scoliosis. Absolutely, there are limitations. But you should be prepared to offer the best and with the least risk. That is the goal.
Yes. Yeah, Dr. Shiju. Points well taken.
Yeah, Vishnu, one little bit regarding this case that is shown up on the screen.
Yes.
One, if you had planned for, sometimes you can plan that rigid part. You can plan for an extra particular few screws, 2 or 3 screws in that area, and your convex osteotomy and postoperative will help in mobilizing that area. And when you do the correction, extra particular screws, as I said, is not strong as a well placed particular screws.
Yes.
So that area
Yes.
you can so your correction has to be on the convex side. If you are able to get a particular screw in the convex side, the correcting side has to be convex side. The supporting side has
Just
to
like
be the
pushing.
concave side. Yeah.
Okay.
The supporting side has to be your concave side, as opposed to the normal way we do.
Okay. So here the extra particular screws would have been much more helpful in this case.
Yeah, much more helpful, and I think probably you'll be able to achieve this similar correction with that kind of
Without
strategy
anterior
also,
approach.
without the opening of the
Thoracic cage
thoracic
cavity.
cage. Sometimes when we do the anterior approach in this kind of fused spine, like what you have shown,
Yes.
the correction that you hope to achieve is not there from anterior correction alone.
Okay.
That is my experience. Neurofibroma cases, we have done few cases. Neurofibromatosis colitis. When we started anteriorly, and then we thought final result is almost similar to what we can achieve posteriorly.
Posterior alone approach.
Yeah. Maybe that is, we don't have any. See, it is very difficult to decide on what to choose in these cases.
Okay.
There is no algorithm.
If at all this patient would have got some decreased respiratory reserves, we would not have thought regarding anterior approach only.
Yes.
So since the patient was having a good this thing, we asked the patient to wait for a month with the good pulmonary function exercises. Then only we took up for surgery. That was the one factor which was tilting us towards the anterior surgery.
Yes, it's a well done. Your planning is perfect, super. I was just adding on to what you told from our unit's experience.
Okay. Thank you. Ram, shall we go for the next case?
Yeah, one question.
Ram.
Extra pedicular screws. Dr. Shiju, you can have.
Yeah. Tell me, what is the question?
Extra pedicular screw.
Yeah. Extra pedicular screws are required when the pedicle is very narrow, a very narrow dysplastic type of pedicle, which you get usually you get in the concave side of the curve. Not in a usually adults in idiopathic scoliosis variety, but when there is a congenital anomalies are there. So that will be very well evident in a CT scan. So it is not wise to meddle with the pedicle and try to check with your luck whether you will get a good pedicle screw in the concave side if the pedicle is so dysplastic. So right away you go for an extra pedicular screw. That from the normal entry point itself, you are doing a in-out-in technique. In-out in technique means the out part is actually you are going outside the pedicle screw, outside the pedicle and go into the vertebral body. It is always better to put a cannulated screw there, because this is a very small area that you can put. So when you do the screw into the very small area, once you used your all and all, since there is no natural channel in that, but it's very easy that it will slip off in different direction, and you will end up in not having a good hold or somewhere not adequate. So I usually do the probing everything and see that my screw is in the body, and then I put the guide wire. The guide wire is put, and or that the tab sometimes goes, cannulated tab goes, and later the screw goes, so that there is, so these areas you can only try once or twice. If you fail once or more than if you're not able to get by first attempt or second attempt, usually you will not get it. So there is no chance of multiple in trials. So you plan for extra particular screw, cannulated screw, the wiper system, whichever system that you're think, and put a cannulated screw. That is much better. But only problem is that we don't have less than 5.2 mm is the lowest available diameter in a cannulated screw.
It's a very important point that you have told. Cannulated screws for extraparticular approach, because you may not have a channel, proper channel. So it's basically outside the pedicle, but within the transverse process and within the body.
Within the transverse process outside the pedicle and into the body.
And supported by the rib from outside.
Yes.
Yeah, Dr. Vishnu, I think one more case and then we'll wind up.
Yes, the last case. It was a case of Schurman's kyphosis of 110-degree curve. Again, a young girl of college-going girl, 110-degree curve. I took so even though it was a rigid scoliosis, I thought I will just finish it off this last rigid kyphosis case. So we took an FULCRUM bending view, and the correction was almost less than 30% of correction we got. So we thought it as a very rigid kyphosis. So this was the clinical picture. So what will be your plan in this case, Ram?
10 or 11. So we might have to do a pedicle subtraction.
T10 is the apex.
T10 is the apex. Of a pedicle subtraction osteotomy.
Okay. Pedicle subtraction that the apex and the prox 2 levels above, 2 levels above Ponte Osteotomy.
Yeah.
Okay. Prince, do you want to add something else? Prince is there?
Actually, he got his wife.
Dr. Shiju?
Yeah. No, this depends upon how much this 110 degree, no? 110 degree. 110 degree.
Yes.
110 degree, right?
Yes, it's for 110 degree.
My aim in this case will be to, my aim in this case will be to get some correction to somewhere 60 to 70 degrees. I will be wary to go beyond that because of the problems that are going to occur in later life. If you correct it more. So this patient, I will be definitely able to correct from invertebra to invertebra by doing a series of Ponte Osteotomies. I am not planning to do an anterior release for him because I feel that in Schurman less is better.
Yes. Yeah. So actually, this was my first case of Schurman's kyphosis. It's done almost 5 years back. So I was not having very much confidence of just doing a posterior approach. So since I thought it's a very rigid curve, I did a limited thoracotomy approach. Just released 4 disc spaces at the apex, and we did an posterior Pontes osteotomy, almost at more of the 6 levels Pontes osteotomy, and then corrected it. So this was the correction we got. But to be frank, I've done almost around 6 to 7 cases of Schurman's kyphosis, almost similar curve of around 600 degrees, almost a very good correction with just posterior Pontes osteotomy alone. So retrospectively thinking, I will accept that this anterior approach was unnecessary in this case. But since there was a first case of Schurman's rigid kyphosis, I was not able to take a clear-cut decision. I went anteriorly. We got a good correction, but I should accept that we can get this kind of correction with just posterior Ponte osteotomy alone.
What level you stopped, sir?
Was it we went till L4.
Okay.
We stopped at L4.
Good, sir. It was a good correction. Despite it being a first case, still it was a good case.
Okay, anything to be added, or shall we finish with this?
Was the correction up to L4 required?
Yeah, he told his first case.
First case, so retrospecting
no.
this, yeah, we would have stopped at L3 also.
Yeah.
We would have stopped at L3 also.
Yes.
So in this case, if at all doing, at present, if I am doing, I would have done just posterior release Ponte osteotomy and I would have stopped at L3.
Correct. What is the follow-up in this case?
So now, 4.5 years follow-up. The patient is in college now. There's no problem. So the patient is doing fine. So the main thing was whether if you are overcorrecting it, the chance of proximal jungle kyphosis is there. That's what they say.
Yes.
We didn't have any problems such that.
Yeah.
I think
it's a problem in Sherman. When you are doing a pedicle screw in the upper, in the upper part, in the upper UAV, if you are doing a pedicle screw, PJK is a problem in Sherman, particularly when you are currently because if you follow up these patients or read the Sherman's paper on this, now 70 now in the UK and all, they have stopped doing Sherman's kyphosis for correction beyond less than 80 degrees.
Okay.
So up to 80 degrees, it's only conservative, unless there is a pain is a factor. Unless there is pain is a major factor. You know that the Sherman's will have some amount of pain because of the epiphysitis. Some amount of pain is there. Is the dictum in Sherman. But long-term studies have shown that up to 80 degrees of Sherman, they do not have a cosmetic concern after some time. After the up to 80 degrees, they do not have a cosmetic concern. But beyond that, it should be corrected. So nowadays, the papers are more shifting towards correction beyond if the curve is beyond 80 degrees.
80 degrees, okay.
And when they advise to do the soft landing in the upper UAV segment. Soft landing in the sense hooks or other angles.
Okay.
But this is a very good correction. Very good. She is very well balanced clinically also. She looks fantastic.
Yeah. So I think the take-home message for rigid scoliosis today is release. So release sequentially. Start with Ponte, go ahead with PSO, and if needed, go ahead to VCR. It's all based on interop, but you have to have some idea that what osteotomy will be sufficient in interop. I think it was a well taken message. Anything to add up, sir? Shiju, sir?
Yeah, no, actually, Vishnu has added up everything.
Yeah. That was an interesting discussion today.
Yeah. I think the participants were probably a little bit less in number compared to usual, isn't it?
Yeah, actually, we will change up the pattern now. It will be more of discussions. Yeah, but it is good. It was useful for the persons who are taking actually.
Yes.
Okay. Thanks for joining.
Okay. Thank you.
Thank you, Vishnu sir.